Hi, everybody. Welcome again today to our second part of preparing for an endosurgery. So today we're going to be discussing further and delving into the details of endometriosis surgery, into the specifics. We started with strategy for the DIE surgery. So we have general strategies and lesion-specific strategies. What are the general strategies? Number one, it starts with sigmoid mobilization using an ultralateral approach, as one of my friend usually alleges it to be. And you would actually go quite high up to make sure that you've freed the sigmoid and the descending colon. You get exposure after this. You have to ensure you get adequate exposure, retain or restore the anatomy. Safeguard the structures. That would include doing a ureterolysis and safeguarding it, opening the avascular spaces, keeping them secure, isolating the lesions, and only then would actually one start by excising the lesions one by one. So you don't attack the lesions directly from the very start. You start from the lateral approach where it's all normal anatomy still outside the pelvis, and then head towards the lesions, but not directly attacking the lesions. So we'll start off with each endometriotic area one by one. To begin with, let's start with uterosacral ligament endometriosis. So what are we to know about the uterosacral endo? Number one, the ureter is usually close and just lateral to the uterosacral ligament and could be densely adherent in endometriosis involving the uterosacral ligament. And the ureter could be pulled medially. So you have to be careful there, and therefore you cannot attack uterosacral ligament nodule without first freeing and lateralizing the ureter. We have to ensure that you remove it completely, because otherwise the symptoms of the patient will not improve. That would really be related to the pain during periods, and especially also dyspareunia. So the approach would be secure the ureter, secure the bowel, keep it aside, ensure a nerve sparing or approach to ensure that you're away from the nerves, and secure the uterine vessels first. Be cautious when you have bilateral uterosacral involvement, especially when it's deep, because you have to take care of the hypogastric nerves that are just lateral to the uterosacral ligament. And it's okay to be more conservative on one side in such a scenario to ensure that you don't at least damage both bilateral hypogastric nerves. Medially mobilize the rectosigmoid by opening the pararectal space to get more space and prepare the uterosacral before you excise it. So you've prepared it laterally by pushing the ureter away laterally. You've prepared it medially by pushing the rectum medially by going in the pararectal space, and then excise the lesion out all the way to its insertion at the torus. Once the uterosacral is exposed dorsally, it can be mobilized and excised from distal towards the torus insertion, keeping watch on the inferior hypogastric nerve, and you may need to therefore start cranially so that you can protect it in the uterosacral area. So start cranially going downwards. Very important now, the next step would be the cardinal ligaments endometriosis. So this is the lateral compartment or the parametrial endometriosis. Usually a very difficult area to deal with, and parametrial involvement, usually you may need to therefore be extremely careful about the uterine vessels and bleeding from it, and the pelvic splanchnic nerves, which may need to be protected in this area, especially as you go deep. You may need to dissect in the Latzgos Okabayashi and the Yabuki spaces to ensure that you are able to protect the areas around it, the nerves especially. You start cranially and laterally and then move medially. Be extremely careful with the depth and lateral extension of the preparation. So the lateral extension of the preparation and the depth of the preparation, you have to be careful, because that's when you may get into the parasympathetic nerve fibers, the pelvic nerves, pelvic splanchnic nerves, especially when it's deep. So this is extremely of importance in parametrial disease. Be cautious in bilateral involvement again at the outer part of the torus. So you have the torus, you have the uterosacral, and then we're talking of the lateral aspect of the involvement. When the cardinals reach the lateral pelvic wall, dissecting it from the healthy tissue near the internal iliac vessels, the sacral root and the parasympathetic nerves might be necessary. And in this scenario, therefore, a mandatory neuropelviology knowledge would be necessary to ensure that you protect the nerves in the lateral pelvic wall side. We now move to ureteric endometriosis. We know that usually it is when the lateral parametrium and the cardinals are involved. That's when the ureter gets infiltrated. Most of the times it is extrinsic involvement where the lesions are outside and they are compressing the ureter from outside. So it is due to the implant itself, due to fibrosis, and due to inflammation that can happen around this ureter. What is the risk? The risk is hydroureter, hydronephrosis, and silent kidney loss, which has been seen in almost 11 to 15% of women as long as they have this endometriosis go untreated. We have to understand that we may have no choice but to free the ureter completely by excising the nodules around it. And you have to free it all around, that is all 360 degrees around the ureter throughout, but keeping in mind that you cannot free it or dissect it within or inside the adventitia layer. You have to ensure that the adventitia remains intact. And you see the ureter actually peristalsing within this sleeve of the adventitia. You don't get rid of the adventitia, in which you have the arboretum of the whole blood vessels that supply this ureter. It is difficult within the ligaments and connective tissue, lateral and dorsal to the uterus. So you have to understand it might be difficult, especially immediately lateral to the insertion of the torus. And you can use bipolar and scissors, you could use the ultrasonic, you could use the monopolar hook, you could use the bipolar shears. So preferably an energy source that you are comfortable with. And keep in mind low lateral thermal damage should be ensured. So use these energy sources prudently in short bursts, and don't do prolonged use of energy. Because that is likely to cause damage to the thermal damage to the ureter. So always ensure adventitia is intact to avoid damage to the microvasculature and inadvertent devascularization that could result from it. Intrinsic infiltration of endometriosis in the ureter is only seen in 2 to 5% of the women, and surgery would depend on the site, the size, the distance from the bladder, etc. So what are the options? Number one is ureterolysis and freeing it from the adhesions and nodules. And this is usually most of the times adequate for majority of the extrinsic endometriosis disease. But you may sometimes need to do an anastomosis, especially in internal involvement of the ureter, where you may need to therefore do an anastomosis and an end-to-end repair, keeping in mind that you'll have to keep certain principles of repair of the ureter in this manner. We'll go into the details shortly. There's also an option of reimplantation of the ureter. If it's very low and it's completely damaged, then you may have to cut and reimplant it by ureteroneocystotomy into the bladder. If you have hydronephrosis and a non-functioning kidney, sometimes you may need also a nephrectomy to be done alongside the surgery. So we start with the ureterolysis and decompression surgery. This is usually for extrinsic involvement, most of the times works, and it's good to know that you have to start from the normal and move towards the affected side. So please don't directly go to the affected, inflamed and fibrotic and nodular area. Start from above and then direct it downwards as you free the ureter all round, medially, laterally, anteriorly and posteriorly. It works even in cases where endo has reached the adventitia as long as no obstruction has occurred yet. So it's usually the treatment of choice for most of these patients. But in some patients, you may need a segmental resection with end-to-end anastomosis. And that could happen when you've had failed ureterolysis, you have an intrinsic lesion in the upper ureter, you could have muscle infiltration with obstruction of the ureter, then you'll have no choice but to resect it and then anastomose these. So you'll have to free the ureter to make sure that you get an anastomosis that is tension-free. How would we do it? You mobilize it first, right from the upper end towards the bladder all the way down. You would then resect the segment that is blocked, mobilize the ends, you'll spatulate it, you will then stent and suture over a stent using a 4O or a 5O monofilament by interrupted sutures, starting with the posterior 6 o'clock suture first, then you would have to go on the sides 9 o'clock, 12 o'clock, and 3 o'clock sutures. Usually it's feasible only when the length is short, and otherwise getting a tension-free anastomosis is usually difficult. So when the length involvement is less than a centimeter, this might work. When it's longer than a centimeter, it might become difficult. What about ureteroneocystotomy plus or minus a psoas hitch or a Boari flap? Well, when is this needed? When you have distal intrinsic lesions, stenosis with length greater than 1 centimeter, or a failed ureterolysis and persistent hydronephrosis. How would this be done? Again, you would mobilize the ureter completely. You would then transect just above the lesion, tying off the distal stump. You would then create a bladder space of red CS dissection to free the bladder and so that it falls off. Do a cystotomy on the dome, then obliquely tunnel into the bladder submucosally outwards to another site onto the serosa so that you have a tunneling that will help as an anti-reflux measure. Then you would stent the ureter, spatulate the ends, and then pull the ureter in from the serosa inwards. And then you would obviously have your stitch and put over the fold of the bladder into the tunneling so that you end up with at least some sort of an anti-reflex mechanism. So this is how you would do ureteroneocystotomy. Once you have fixed the ureter to the bladder mucosa, again using 4O or so monofilament interrupted sutures, you would then close the bladder, leaving the catheter and stent in place, stent for around 6 weeks, catheter for at least 10 to 14 days, and always do a 6-monthly KUB scan in such patients to avoid missing out silent hydronephrosis that could persist afterwards. So it's good to keep a watch on such patients so that you ensure it doesn't get stenosed by any reason later. We go into the bladder endometriosis now. So this is defined as involvement of the detrusor muscle, and normally you would rarely have it up to the mucosa. So as long as it's on the peritoneum of the bladder, I don't think we would call it bladder endo. It would still be peritoneal endo overlying the bladder. So that is okay. So you have to ensure that there's some infiltration into the bladder muscle and occasionally up to the mucosa. The rules: know the location beforehand, so have a good assessment beforehand. Is it at the dome? Is it how close is it from the trigone? Very important to understand before you start tackling such endometriosis lesions. Know the state of the kidneys and the ureters. Ensure that you don't have a hydroureter or hydronephrosis. If possible, do a cystoscopic evaluation before the lap surgery to see if you can have any lesions that are actually coming in to the bladder mucosa, because you'll see it. And if that is so, then it's good to delineate it and know that it's this far from the trigone, because otherwise the need for stenting might be necessary. So intra-op, you will usually see the round ligaments pulled in medially, and you will see fibrosis in the anterior compartment whenever there is bladder involvement of endometriosis. How would you start tackling bladder endo? You would start from normal tissue again towards the lesion. Don't attack the lesion directly. The best approach would be a lateral approach. Free it from the round ligament all the way. Free the peritoneum, go below, free the bladder. Don't attack the nodule that might be in the center. The nodule and the posterior bladder wall needs to be freed of the cervix last before resection. So you can't proceed by leaving the nodule stuck to the cervix. You will have to free it off the cervix to be able to tackle it properly. So you go into the vesicovaginal space. If it is too close to the trigone, you may need to consider stenting. You'll have to free the nodule from the bladder from all sides before stitching it up. So it's not enough to just take a part of the nodule. If you don't free it from the rest of the mucosa and the wall of the bladder, it will recur and continue growing. So you'll have to open the bladder up and now attack it from the inside, seeing the lesions, and then excise the whole of that nodule out before closing it up. You can use a continuous single layer closure. You can use the monofilament, 3-OPDS or V-Lock has been used, and even Vicryl can be used for repair of the bladder. We try and ensure that it's watertight, so start with the angles and then close from one to the other so that you don't miss out the angle. And check post-op with 100 to 200 ml of methylene blue saline that could be used to retrogradely fill it up and ensure that it's watertight. Leakages can be managed by single interrupted sutures in between. Leave the catheter in situ after this for at least 7 to 14 days, following which you could do a cystogram to check the bladder and then pull out the catheter. If it's a large bladder resection, open the space of Redzias to allow tension-free repair, so let it fall down. Don't let it be retained stuck to the anterior abdominal wall. Bladder and uterine adenomyosis can be a challenge, especially if this uterus is to be preserved, because if there is adeno in that area, you will not be able to resect all of it. So you resect the bladder nodule, but you have adeno here, it's going to regrow into that bladder. So it becomes a challenge when you have adeno at that area near the bladder nodule. And what is the role of a post-op cystoscopy? Unsure, but maybe in 10 to 14 days, that could also be done if you want. If you get hematuria after, then there's a risk of the catheter being blocked with the clot. So if possible, in such cases, if you're unsure, use a 3-lumen transurethral rinsing catheter. So you use a 3-lumen catheter so that you can rinse it. Remove the stent if you had put it after around 6 weeks. Check the ultrasound check the ultrasound kidneys before discharge from the hospital whenever you've done a bladder or urethral repair. Make sure that the suture, you'll usually see that the suture insufficiency or bladder leak is extremely rare as long as the catheter has been left in situ for some time. So make sure it's not removed immediately. And you can sometimes use anticholinergics to reduce bladder irritability, especially if the stent has been left in place, because that could irritate the ureter and cause cramping and colic pain. What are the risks of bladder surgery? It could be secondary hemorrhage into the bladder, reduced bladder capacity, especially if you excise a big nodule if it was quite large, a urinoma if you could get a leak, peritonitis with urine could happen, post-op hydronephrosis if the injury was very close to the ureter and by mistake you took a stitch or blocked it up, and sometimes a fistula, especially to the surrounding structures, if you had a concomitant second lumen open surgery like a bowel surgery or like a vaginal surgery, for example a colpotomy to do a TLH, then you have to be careful because these two suture lines could form a fistula. I think with this I would like to come to the end of part 2 of preparing for endometriosis surgery. And we'll delve into the part 3 of the endometriosis surgery in our next video, which will be coming soon. We'll be covering bowel endometriosis and diaphragm endometriosis and intestinal or appendiceal endometriosis and the like. Thank you. See you again next time.